Biometry is an art and it requires methodical planning and implementation. So here we have made an ophthalmic cubicle which harbors all the instruments required for patient evaluation during this COVID era without compromising the patient as well as the healthcare workers' safety. The first step would be proper patient positioning. Proper back and head position with comfortable seating is required for flawless analysis, and we have been able to achieve that in this cubicle. At first, optical biometry is done, and it is imperative that we measure both eyes. Always advise the patient to blink just before acquiring each measurement. Whenever an alert is noted, that value needs to be deleted and retaken. Following acquisition, we need to validate the data, verify the patient information, and then the measuring mode. Never overlook such highlights. Here it means that there is significant difference in the axial length between the right and left eye. The difference noted is more than 0.33 mm, which is an indication for validation. Always verify the standard deviation. It should not be more than 0.05 mm. Keratometry analysis is done to verify the average K and the type of astigmatism between both eyes. Here we have an against the rule astigmatism with similar values in both eyes, and the readings are reliable as the standard deviation of axis is less than 3.5 degrees. And then we have the iris barycenter, which is the angle alpha, and the pupil barycenter, which is the angle kappa. The cumulative of these decentrations along the x and y axis gives us our angle kappa and angle alpha respectively. Manual keratometry is done for those with mature cataracts. Keep in mind to ask the patient to blink just before confirming the data. Always check for absolute overlap of Myers before confirming the values. In cases of irregular astigmatism, you will notice such irregular Myers with difficulty in overlapping. Corneal topography using Scheimpflug imaging is done for all patients to rule out irregular cornea and to assess the toricity. The corneal map is assessed to rule out any eccentric thinning. And we can also evaluate the pattern of corneal astigmatism. Here we have a symmetrical bow tie pattern with no skewing of the radial axis, which is an indication of regular astigmatism. The posterior elevation map is looked at for any posterior steepening. The summary indices helps us know the thinnest location and how thin it is and how far it is from the center. In the K readings, the simulated K value needs to be looked at to compare with that of the manual keratometry or the optical biometry. Here the K1, K2 as well as the amount of cylinder can be compared. Then the refractive analysis can be used to compare with the patient's PG glass power. Then we have the keratoconus screening where the symmetry of the front and back can be assessed using these indices to rule out irregular corneas. Dry eye evaluation is done using the Sirius topographer to assess the tear film breakup time. This helps avoid staining the cornea. immersion biometry is done for those with dense cataracts. Here we have a top-mounted shield to help reduce the patient exposure and contact with the ophthalmic assistant. Always verify if all the 10 readings have been recording before confirming the value. There are many modes available in our machine, for which there is varying velocity and gain. We have different modes for dense cataract, for aphakia, for eyes filled with silicone oil, and for pseudophakic eyes. And make sure that it is on the immersion mode and not on contact mode. Always start off the validation by verifying the patient information and the eye of the patient, following which check the measurement mode. The standard deviation should always be less than 0.05 mm. All the echoes should be of adequate height. Here we have the corneal echo, the anterior lens echo and the posterior lens echo. The vitreous should be echo-free. If there are any echoes, then it needs to be correlated clinically. Takeoff angle of retinal spike must be 90 degrees with the baseline. The retinal and the scleral echoes should also be seen. And for ion power calculation, the input parameters should be verified along with the ion formula, following which the A constant should also be verified. Iodine eye drops are instilled 5 minutes prior to measuring the intraocular pressure using the non-contact tonometry. Validation of axial length needs to be done for the following conditions. Similarly, for the conditions listed below, validation of keratometry needs to be done.